Okay, are we?
Azhar, can you make it start the webinar, please? Azhar. Yes, we're live. So we'll just wait for the attendees to join. One more minute.
Okay, I will wait for a minute.
We can start.
Okay, Assalamu alaikum wa rahmatullahi wa barakatuh, everyone. My name is Dr. Ibrahim Jalidan. I'm a consultant adult cardiology and heart failure specialist from King Faisal Cardiac Center, National Guard Health Hospital, Fair Jeddah. I would like to welcome you all in this first of many, inshallah, webinars to come covering heart failure from different aspects. First of all, I would like to thank the National Heart Center, and I would like to thank Dr. Adil Tash, Dr. Wael Gashgari, both representing the National Heart Center, especially Dr. Adil Tash representing the National Heart Center. He is keen in optimizing and improving healthcare outcome, cardiac healthcare outcome, especially in heart failure patient. And hopefully this webinar will not be the last. We'll have, inshallah, more to go. You will have an email by the end of this webinar with the recording of this lecture. So you can go back and review some of it, inshallah, if you find it useful. Also, I would like to thank Dr. Ismail Raslan and Dr. Andres Fernandez, both our speaker. I'll introducing them one by a time, inshallah. And the way we will do it is we will start by a small introduction about the iron deficiency anemia, how common is it in heart failure patient, and what's the mechanism of that. And then that will lay the ground for Dr. Ismail and Dr. Andres to talk about management of iron deficiency anemia in heart failure patient in details. And Dr. Fernandez will be discussing managing of iron deficiency before going for major surgical procedures. Any question you have, please don't hesitate to type it in the chat. We will have a specific time to answer all the questions at the end. It will probably take us around an hour to an hour and 10 minutes for this webinar today. And I will be starting, inshallah. So I will be sharing my slide. So everybody can see the slides. Okay. So why we're talking about this subject? First of all, cardiovascular disease burden is really huge, especially heart failure. I can refer everyone to review this nice article that was done by Dr. Tash and Dr. Rachel Bawardi about this topic, basically about the facts and challenges of cardiovascular disease in Saudi Arabia. And just glances from this article is about the burden. We do have high burden of cardiovascular disease around the documented number we have is around 200,000. Probably it's more than this that we have in Saudi Arabia. It's still carrying a big burden on the healthcare system, with cardiovascular disease account for over 45% of all cause death in the country. Heart failure, we don't have a specific set of data about the exact number of heart failure in our population, but extrapolating the data from worldwide prevalence of around 1 to 2%, if we accounted to around 29 million population in Saudi Arabia, we will be facing a number of around 400,000 heart failure patients in our country. And the economic burden is very high, as you can see, with around 3.5 billion in 2016, and that number will raise actually in the next few years to reach 9 billion. So we do need to use any tool we have to improve and to decrease this burden of cardiovascular disease. And heart failure is one of the major player in this burden. So heart failure is a progressive disease, as you know. This is a very common slide that we always like to see and present, reflecting the nature or the prognosis of heart failure patient from the green part on the left of the screen, indicating that patient at risk, which is stage A heart failure, should be evaluated and managed even before they develop the disease. Then they will develop the disease initially with a period of stability, and that's the nature of this disease. And eventually, this stability will start to replenish, and they will get worse and worse until they reach the stage of advanced heart failure. So we need to focus and treat the patient while they are stable or possibly stable in the yellow area with all the tools that we can use. So it's not only just medical therapy, the four pillars that we know, but we need to use in another tools as we're going to discuss today. And why heart failure is bad? Because even with all the progress that we are achieving in the last few years, we're still carrying a five-year survival rate of 50%. And actually, it's worse than most cancers. Like actually, two cancers only in men and women is carrying a worse prognosis than heart failure. But I don't think we have a lot of resources directed to the heart failure as for example, oncology carry or have. And people will say we do have a lot of medical advancement right now, and I agree with that. We were only treating patients with a couple of medication. Now we have the four pillars of medical therapy. But if you can see to this graph, actually data taking from the empagliflozin trial. So the empagliflozin, dapagliflozin, the SGLT2 inhibitor were the last to join the pack of heart failure management, showing a great results in improving heart failure hospitalization, cardiovascular death. But if you can see from this data, following the patient up to 7 years, we still have a rate of 30% to develop cardiovascular death or heart failure hospitalization, although those patients are on quadruple therapy with very good percentages, as we can see on the right side of the screen. And if we compare, that's why I love this slide, heart failure to cardiovascular disease like the atherosclerotic cardiovascular disease, the one that we direct a lot of resources to in terms of lowering the risk factors. We actually, very high risk patient with a residual risk patient represents 7% cumulative risk. And if you compare that to the heart failure, a stable heart failure patient with NYHA2 actually carry a residual risk of having a heart failure event of around 20%. So it's almost 3 times the residual risk for atherosclerotic heart disease. So it's a very important topic that we have to use any tools that we can. So that's why we're discussing iron deficiency anemia today. And aims of treatment of heart failure is not only to improve survival, we need to focus, the first thing we need to focus on is to improve patient symptoms. And by improving their symptoms, we will improve eventually their quality of life and stop progressing the worsening of the disease. That also we need to prevent hospitalization, because we know that hospitalization will drain the healthcare system, especially with the heart failure being #1 reason for hospitalization in cardiovascular disease. That will work for both HFrEF and HFpEF population, maybe not less so for the survival part for the HFpEF population, because we know they usually die from other than cardiovascular disease. So in the HFpEF population, actually, we really focus on the first two parts with improved symptoms and prevent hospitalization. So before starting about the burden of iron deficiency anemia, we need to understand what is iron deficiency anemia. So I believe both doctors will probably touch on that again, but I think we'll just repeat it so everyone will be in the same board. So basically, iron deficiency is when the patient iron supply is insufficient to meet the body needs. Either by that we're losing iron and we're not able to cover it, or there is some pathological process happening that caused the iron to be deficient. And there's a lot of definition, and there's a lot of criticism about different definitions, but I will focus mainly on the ECS definition, which is basically a ferritin level less than 100. So that's basically reflecting that the store is depleted, which is called absolute iron deficiency. Or if your patient store is good, so the ferritin is 100 to 300, but there is a problem with utilization of that store, so it's called functional iron deficiency. That's when your transferrin saturation is less than 20%. And how common it is in heart failure population. So this is like, we can go through a lot of data, but I chose this registry because of the how well it was done, and also the recency of those data. It's actually a Swedish heart failure registry looking at total heart failure population, HIF-RIF, heart failure with moderate reduced ejection fraction, HIF-PIF, and looking at iron deficiency anemia prevalence. So if you can see, iron deficiency by itself in the top is around representing 55% of those populations. So it's very common. It is associated with anemia in around 36%, so almost third of the patient, and iron deficiency without anemia is around 20%. So it's a big population that we will have iron deficiency in. And across the three types of the heart failure according to the ejection fraction, they're almost equal, maybe a little bit more prevalence in the HIF-PIF population, and I think that's probably more understandable. And we know that iron is very essential to all organs of the body, but we'll focus here in the heart and the skeletal muscle, and their role usually basically is emphasizing in improving the function of the mitochondria, and basically its energy utilization. So it's important to utilize energy, and the lack of iron basically will cause disturbance in the energy utilization in the heart and the skeletal muscle, and those are important for heart failure patient. Why it's happening to the heart failure patient? Due to a lot of reasons. I'm not going to go through all of them, but either they have reduced iron absorption, they have gut edema because of the chronicity of their heart failure. So they're going to be having low stores. We have worse GI bleeding in heart failure population, probably because a lot of them are on antiplatelet anticoagulation because of underlying coronary artery disease. Or we can have reduced iron intake, decrease because of, for example, decreased PO intake, specific diet, cardiac cachexia in heart failure patients. So there are a lot of reasons why iron is low in heart failure population. And if we look at the same registry that we mentioned before, the heart failure one, the Swedish registry, we can see that the screening for heart failure, for iron deficiency in heart failure, is starting to pick up in the last few years after having multiple trials now showing the benefit of iron IV replacement. And it's important to notice in the paragraph in the middle that it's not always necessarily present in the baseline. So when you see the patient, they can be okay, and after 6 months or 1 year, they can have iron deficiency anemia. And we know from this registry that those patients with iron deficiency and heart failure, they have worsening heart failure hospitalization and cardiovascular death. So that's why we need to screen those patients and need to treat, because it's linked with worse outcome in an already population that's very high risk as heart failure population. One study only I wanted to mention, it's actually an interesting study. It's a small study, only around 90 plus patients were identified as a non-ischemic heart failure. So they had all cath and they were negative in terms of coronary artery disease. And actually they consented the patient to do endocardial biopsy, although not all of them were indicated. And when they looked at the iron content of the heart muscle, the lower the iron content in terms of the analysis, those people had higher NT-proBNP, worse remodeling, and high LV filling pressure, and they actually did worse than the people with high iron or normal iron concentration in the cardiac muscle. So we know right now that it is a very common issue that's affecting a population that's carrying a very high risk of hospitalization and draining the burden of our healthcare, making a burden on the healthcare system. So that's why we need to treat this disease very carefully. So that's by this will end my lecture for today, and I will be ending the screen share, and I will be introducing my next speaker. So next speaker is Dr. Ismail Raslan. He is an advanced heart failure and transplant cardiologist, and also specialized in cardio-oncology, working in King Saud University in Riyadh. Recently joined us in the last few months, coming back from his scholarship in Canada. And he is going to talk to us today about management of iron deficiency in patient with heart failure in more details, exploring some of the evidence behind what we do. We will be speaking about this for around 20 minutes. So the floor is yours, Dr. Raslan.
Thank you very much, Ibrahim. To confirm, can everybody see my slide?
Yes, it's
Yes,
clear.
Dr.
Okay, thank you very much. I'm delighted to be with all of you today. I'll be speaking about the management of iron deficiency anemia in patients with heart failure. Dr. Ibrahim has laid down some of the groundwork that I intend to disclose with you as well. I have no disclosures for this talk. To start off, I have these three scenarios that I've put forward to you, and the hope is by the end of this talk, we will be able to answer these questions. So to start off, who gets IV iron? You have a 67-year-old male with ischemic cardiomyopathy, PCI to the LAD that was done in 2022 after a presentation with the STEMI. The first patient profile is a patient with an NYHA class 1, ejection fraction of 30%, a hemoglobin of 11, a ferritin of 28, and a TSAT of 12%. The second patient profile is a patient with NYHA class 2. He shares the same ejection fraction, the same hemoglobin, ferritin, and TSAT as well. The third and last profile is an NYHA class 3 patient, same EF, same hemoglobin, a higher ferritin, and the same TSAT. Ibrahim already tackled on this earlier, but I wanted to point out that iron is an essential trace element that is involved in a plethora of crucial biomedical and important pathways in our body that are important for tissue metabolism. Ferrous and iron exist in really two main forms in our body. So you have ferrous, which is Fe+2, which is primarily intracellular, and ferric, which is Fe+3, which is extra and intracellular. Now, really, when you're looking into iron deficiency anemia, it's important to keep in mind that iron deficiency anemia is one of the most common nutritional deficiencies worldwide, affecting approximately 1/3 of the general population. On average, we consume about 10 to 20 milligrams per day of iron, and the iron hemostasis is exclusively regulated through the iron absorption through the apical surfaces of the enterocytes. And from those 15 to 20 milligrams, we have about only 15% that actually gets absorbed into your systemic circulation. So really don't have a full answer to why patients with heart failure develop iron deficiency anemia, but if we were to put them into groups, it's either reduced absorption, increased loss, or reduced iron intake, or a deficiency or a problem in utilization. And the most prominent role of iron is oxygen homeostasis, and including oxygen transport, storage, oxidative metabolism in the skeletal muscles and the cardiac muscle and mitochondrial functions as well, also plays a role in metabolism of lipids and proteins. But ultimately, in the end of the day, what happens is you have deficiencies in your heart, which results in altered calcium handling, adverse remodeling, and decreased contractile reserve. Dr. Ibrahim showed you how NT-proBNP in these patients can also be elevated. You see the same fashion in skeletal muscles and also other processes. But in the end of the day, what you're looking for is a net in decreased exercise tolerance, a decrease in quality of life, increased depression, increased hospitalization, and also an increase in mortality. This is a very important graph that depicts how anemia is independently associated with heart failure, severity, and mortality. And as the lower your hemoglobin gets, the more likely you are to die and less likely you are to survive. And iron deficiency, which can be present with or without anemia, can be seen in up to 50% in patients with chronic heart failure and up to 80% in patients presenting with acute decompensated heart failure. As your heart disease progresses, as your NYHA class worsens, your iron stores deplete, and also your hemoglobin depletes as well. This is a very interesting study that looked into 157 patients. And as you can see, the transferritin saturation keeps falling down as your NYHA class falls. But in NYHA class 4, you have 100% of the patients in this population with a TSAT that is less than 20%. We've made a lot of progress since 2009 with the FAIR-HF trial, and we still are. But despite that, there are still questions to be answered. From the literature, I've picked for you several key important trials, which we will go into very shortly. To start off with the FAIR-HF trial, the clinical question was, in patients with symptomatic heart failure with reduced ejection fraction and concomitant iron deficiency, does IV iron improve heart failure symptoms in comparison to placebo? There were 459 patients that were provided with IV ferric carboxymaltose versus placebo in symptomatic heart failure patients. So the EF at that time was less than 40%, NYHA class 2 to 3, or an EF less than 45 with an NYHA class of 3. The definition of iron deficiency anemia, and this is the theme that you're going to see, and Dr. Ibrahim touched on that as well, a ferritin that is less than 100 or a ferritin between 100 to 300 with an iron saturation of less than 20%. And as you could see, there was clearly evidence of symptomatic improvement on the self-reported scale, on the NYHA class, on the 6-minute walk test, and also different scales and questionnaires as well. But what was also important in the FAIR-HF trial, that this was irrespective of anemia. Moving forward to the AFFIRM-HF trial, treating patients with acute decompensated heart failure. So the setting now is a little bit different. So this is after the hospitalization of acute heart failure. They're improving right now. They fulfill criteria, as we mentioned before, when it comes to iron deficiency anemia. They have an LVEF of less than 50, and basically their hemoglobin is between the 8 to the 15. And the primary outcome was the composite of total heart failure hospitalization and CV death at 52 weeks. There was other secondary outcomes, as you can see on the right side. But really what happens is they get screened, they're stable, they're randomized, they go into a correction phase, and then throughout the study, if their iron stores remain low, then they get replaced. As you can see over here, this is the protocol that was used, and we'll get to the protocol later when it comes to how you would dose these therapies. But one thing is clear, that the majority got at least one dose of IV iron. And the primary outcome, which was total heart failure hospitalization and cardiovascular death, did not meet statistical significance at 0.059 with an absolute risk reduction of 15.3 per 100 patient years. The total heart failure hospitalization was statistically significant at 0.13 with an absolute risk reduction of 11 per 100 patient years. Other secondary outcomes here pointing your attention to first heart failure hospitalization or cardiovascular death. Moving on to the Ironman study. The Ironman study looked into another formulation, which is the ferric deoxymaltose, and in a relatively similar fashion, the patients were randomized to receive IV iron replacement versus standard of care, and the primary outcome was a recurrent of heart failure hospitalization and cardiovascular death. And below is the protocol that was used. And again, in this study as well, it was not statistically significant at 0.70. And then there was a sub-study looking into a sub-analysis looking into the primary outcome when censored for September 2022 due to COVID, and that was statistically significant at 0.047. Looking into the rate of hospital admissions for heart failure, stroke, or myocardial infarction or cardiovascular death, it was statistically significant at 0.045. Moving on to the HEART-FID trial. So the HEART-FID trial was a double-blinded, placebo-controlled, event-driven, randomized control trial. And in a similar fashion, it included patients with an EF that is less than 40%, with iron deficiency. And the key inclusion criteria was iron deficiency, which is in keeping with the literature and what we have discussed before, a ferritin less than 100, or 100 to 300 with a TSAT that is less than 20%, heart failure hospitalization, and elevation of congestion. This was the dosing that was used. And the primary endpoint was a hierarchical composite of all-cause mortality at 12 months, heart failure hospitalization, change in 6-minute walk, and the top secondary endpoint was CV death or heart failure hospitalization. So as you can see here, this is the primary hierarchical endpoint. And starting off with all-cause mortality at 12 months, the number the absolute risk reduction was 1.7%. That takes you down to the total heart failure hospitalization with a calculated 270 fewer heart failure hospitalization and a change in 6-minute walk test of about 4 meters. Now, the p-value is of 0.019, but this shows basically marginal improvement with IV ferric carboxymaltose versus placebo, but the p-value that was set for significance would have been less than 0.01. And when we're talking about the win ratio for this trial, what happens if I could focus your attention for 30 seconds? On the left side here, you're looking at the deaths at 12 months. So 18% of these decisions that are occurring after this study was as a result of the first part of the study. That tells you that you have a win of 9.8. So wins are likely referring to the instances where the treatment resulted in better outcomes, and the losses is, on the other hand, where it resulted in less favorable outcomes. And basically, the majority of these patient ties, and then basically you calculate the difference and the percentage that tells you the overall win, which is 20% more wins in patients with iron replacement. That takes you down to your second hierarchical endpoint, which is hospitalization at 12 months, and then the changes in 6-minute walk test. Going on to the top secondary endpoints, which is cardiovascular death and heart failure hospitalization, it was not statistically significant. The other question that comes to mind is, what about oral iron replacement? And oral iron replacement does not improve exercise capacity in patients with heart failure and reduced ejection fraction and iron deficiency anemia, as evident in the Iron Out trial. Looking into several key systemic reviews or meta-analyses, this is the first one that was published, the first one I have for you that was published in the European Society of Cardiology, that looked into 10 randomized clinical trials, including the Ironman trial. And what you can tell is the composite outcome of CV death and first heart failure hospitalization was significant. All-cause mortality crosses the unity line, cardiovascular mortality as well, hospitalization for heart failure, and hospitalization, that was the first event, and the hospitalization for heart failure in total is favorable for iron replacement. Another meta-analysis that was done that focused on ferric carboxymaltose in these patients with about 4,400 patients with the same definition as we have mentioned before. When it comes to the total CV hospitalization and CV death, was significant at 0.029, a relative risk reduction of 10%. Moving on, the total CV hospitalization of 0.009, which was statistically significant. Again, we see the same trend for total heart failure hospitalization. One important thing as well to note that the lower your TSAT, the more likely you are to benefit from IV iron replacement. Switching gears to the management, the definition, as we mentioned previously, remains the same at the very bottom line. And I wanted to point your attention about the WHO definition for anemia, so less than 12 in women and less than 13 in men. So what is the suggested initial testing? At this point, you really need to put on your internal medicine hat and make sure you're not really missing anything. By the least, I suggest having a complete blood count, including red cell indices, reticulocyte count, and sometimes, if indicated, a peripheral blood smear, a complete set of iron studies, kidney function, a C-reactive protein, an erythrocyte sedimentation rate, because it can tell you in the sense where your ferritin is borderline if there's underlying inflammation, and a serum B12 and folate can be helpful. So what does the guidelines tell us? So the American guideline tells you that for your patients with heart failure, you should be doing an iron study. This is also in keeping as well with the European Society of Cardiology. They also mention that you should be doing it also pre-discharge. And I wanted to point the point about pre-discharge because you want this acute decompensation to settle down to get a better understanding of your ferritin level for these patients. And basically, when it comes to the management for anemia, the American guidelines tells you that in patients with heart failure and reduced ejection fraction and iron deficiency, with or without anemia, intravenous iron replacement is reasonable to improve functional status and quality of life. On the same hand, the European Society tells you you have to look for it, you have to keep it on your radar, and they also mention that the EF cutoff and what is the definition of iron deficiency in these patients. The Saudi Heart Association as well has guidelines discussing these topics that really mirrors what the European Society mentioned and also tells you about how you would administer ferrous carboxymaltose. So I really want to focus our attention on this particular slide because I think this is the take-home message that you need to take. Part of this is missing here, but at the very top, it says chronic heart failure, NYHA class 2 to 4. And I really wanted to drive this point home because you need your patient to be symptomatic. At least that's what the evidence suggests. And that's what the clinical trials tell us right now. And that's where we're building our guideline recommendations with a 2A right now. So first of all, put your internal medicine hat, make sure we're not missing anything else, but also confirm that you have a diagnosis of iron deficiency anemia. As we mentioned, a ferritin that is less than 100 or 100 to 300 with a SAT that is less than 20%. Now ask yourself, does your patient have anemia or not? So if your patient doesn't have anemia with the hemoglobin of more than 15, really at the time being, we don't have enough clinical data to support replacing iron in these populations. Now, if it was less than 12 in a female, less than 13 in a male, then basically you have anemia and you have iron deficiency anemia. Again, as we said, make sure you're not missing anything else. And then for patients who are not anemic, so more than 12, less than 15, more than 13, less than 15, make sure that you're not missing anything else, primarily a malignancy. Ask yourself and your patient, are you up to date, for example, on your routine screening? And then you would calculate the iron deficiency in this patient. There are several calculations that you could use, but this is a good graph that really helps guide you. So hypothetically speaking, if we were to talk about the patients we presented in the initial part of this talk, the hemoglobin was 11. And then you needed to decide based on their weight, how much do they need? So if there's somebody who's more than 70, you can tell that your patient needs 1.5 grams of IV iron. We're talking here about ferric carboxymaltose. Keep in mind that you should not be giving more than a gram of iron, of ferric carboxymaltose for these patients. So I give this patient the gram, as you can see here, depending on the weight. So let's say 70. And then I bring him back at 6 weeks and I give him 500. And in between this time, I do not look again. I don't check what my stores are because I know my deficiency is 1.5. But then again, I have to keep on looking and I have to make sure that the stores are replete. So you check again at 12 weeks and you check again at 24 and you can check again at 36 and you ensure that your patient is fully covered throughout that time. So when you're seeing a patient, you have 3 phases: the clinical assessment, the correction phase, and the maintenance phase. Going back to our previous initial slide, so for the 67-year-old gentleman, NYHA class 1, the rest here qualifies. But really, at the time being, we don't have enough information to guide us for NYHA class 1. This patient, NYHA class 2, hemoglobin fits, ferritin fits, TSAT fits, so definitely. This third patient, which is NYHA class 3, EF fits, hemoglobin fits, ferritin is not on the lower side, so this is where we rely on your TSAT. So this patient also gets IV iron replacements. So in conclusion, it's very important to know the patients who are likely going to benefit from IV iron. Early detection and identification and intervention is very important. Make sure that you keep an eye on other causes that could cause your patient to be anemia. And from what we have right now, we can tell that IV iron improves your NYHA class, improves your symptoms, your 6-minute walk test, your quality of life, and decreases your heart failure hospitalization and your CV hospitalization. Mortality, when it comes to the randomized clinical trials, is something that still needs to be explored for more statistical strength. Oral iron does not work for these patients, and keep in mind that IV iron is not a one-time thing. You give the iron that the patient needs, but you have to continue and keep on checking as you move forward. Thank you very much.
Thank you very much, Dr. Ismail Arslan, for this excellent review about the evidence behind iron replacement in heart failure patient and this actually very practical way of how to deal with those patients. We will leave the question at the end of the second talk. So we'll move on to the second speaker. So Dr. Andres Fernandez, he is a cardiac anesthesiologist, also working at King Faisal Cardiac Center, National Guard Health Affair in Jeddah. And he will be talking to us about a subject that's growing right now in the literature, which is management of iron deficiency in patients undergoing with cardiovascular disease who are undergoing major surgical procedures. So Dr. Fernandez, the floor is yours.
Okay, good night. I'm going to share my screen right now. Let me know if you have it in there. Did you see it?
For me, not yet.
Dr. Fernandez, can you just click next?
And next.
Started to appear right now.
You have it now?
Yeah, but still, I think you need to put it in the show mode. Yes,
It's already in the show.
it's ready, right? Excellent.
Okay, well, so the topic for today on my side is management of the iron deficiency or iron deficiency anemia in patients with cardiovascular disease undergoing to major surgical procedure. So you need to put in the equation two different things. So those are patients with cardiovascular disease, iron deficiency anemia, and or iron deficiency who are going to get surgery in the next maybe 4-6 weeks. Yes, we are talking about elective surgeries in patients with heart failure. In the previous presentation, we already knew how is diagnosed iron deficiency anemia and how we will deal with these patients just pre-op. So the definition, we will just carry on with the whole definition, hemoglobin 12 grams per deciliter for women, 13 for men. So this is kind of a topic of discussion because there are many things that can change. So you see that depending on the population, for example, in cardiac or major abdominal surgery, so women with the hemoglobin borderline, let's say 12.9, receive more RBC transfusion and or had longer post-op length of stay in hospital compared to those patients with normal hemoglobin. But look at that, it's just 12 to 12.9.
Dr. Fernandez, we cannot see your screen, please.
Oh, really?
Yeah.
What about now?
We still can't see it.
I'm not sure. Maybe you can try stop sharing and sharing again if there's a glitch.
Stop sharing. Now?
Please double click.
Double click on the screen or?
Now it's up, yeah.
But your camera is gone.
Oh, right.
And that's okay. Let's
It's okay now?
yes.
Are we okay?
Yeah, we can see the
Oh,
slides.
okay. So as I mentioned before, so we have this WHO definition about iron deficiency anemia or anemia. It cannot fit for every single population. So for example, in this very nice article, the patient who underwent to abdominal surgery, so with borderline values of hemoglobin 12 to 12.9, all these patients received more RB transfusion and had longer hospitalization stay than those patients with normal hemoglobin. So just put this in the context of a patient with a reduced ejection fraction. So you will already know that if this patient requires some extra volume, so maybe you will have you will get into troubles while you are doing the surgery on these kinds of patients. So the value of this 12 to 12.9 hemoglobin based on the WHO definition maybe is not really good for the patient we're gonna take into the OR. So brief resume about how is the iron working in our body. So in this lower left square, the section B, this is the kind of patient with the iron deficiency anemia. So you can see that in the enterocytes or the macrophages, they have a very small amount of iron. Lab-wise, that's going to be ferritin. So ferritin is a way you storage the iron in the body. So this patient will have a low ferritin. So it's able to secrete the iron into the blood and is captured by the transferrin. So you see a good amount of transferrin there, but there is not enough iron in those things. That's why the transferrin saturation is low. We have low ferritin, low transferrin saturation. This iron is taken to the bone and is produced erythrocytes. So that is a very important feature. Low ferritin and low transferrin saturation. On the other corner, so the part C is typical of the inflammatory or chronic anemia, chronic disease chronic disease anemia. So you will find that in the guts, you will find good amount of iron as well on the macrophages. So good amount of iron. Ferritin level maybe is around 100 to 200 or more than 200. The problem here is the inflammation just produce a very positive pathway in the liver and produce this cofactor called epsilon. The epsilon just close the door from where the iron is just secreted in the blood. So at the end of the day, you will have less iron there in the blood. The transferrin is not going to be completely saturated, and you will have anemia. What is the big difference here? Your ferritin is going to be high, and the other side, the ferritin is going to be low. That's the difference between the iron deficiency anemia or the anemia for inflammatory process. That is very often seen in patients just taken for surgery. So the iron deficiency anemia, just talking about the epidemiology and clinical implication, is a very important health issue. 2 billion people around the world are suffering of iron deficiency anemia. So on top of that, if you add those patients who has a functional iron deficiency anemia or iron sequestration secondary to the inflammation, so when you read some papers, they say that maybe roughly 2.5 billion of people are carrying this kind of anemia around the world. So that's why detection and management of the perioperative anemia is something very important, because if you just face the surgery with a low concentration of hemoglobin, the risk of being transfused during the surgery is very high. And we all know that just RBCs given as a therapy are not the best choice for the patient. So again, if you have this patient with a low ferritin and you are not completely sure if my patient is iron deficiency anemia or something else, it's always good to check or ask for inflammatory biomarkers. You can ask for the CRP. CRP is normal, ferritin is low, transferrin saturation is low. Most likely you are facing a patient with iron deficiency anemia. On the other hand, if your CRP is slightly elevated, so you can think about anemia of chronic disease or secondary to inflammation. So again, how define anemia? You can do it based on the mean corpuscular volume. You have microcytic, normocytic, or macrocytic anemia. So we're just going to concentrate on the left upper quadrant. It's microcytic anemia. Most likely, basically, it could be maybe an iron deficiency anemia. What you order an iron profile. So you have a low ferritin and you have a low saturation. Most likely, you are facing a patient with an iron deficiency anemia. So I just went through this study because it was very interesting. The name of the study is Empire. They just gathered almost 8,000 people. Was done just in Portugal, and they showed that the in the iron deficiency, most of the people have a ferritin less than 30 nanograms per milliliter, and this was the more prevalent disease that they face in the adult patient in Portugal. So 32 versus 20% respectively. And it doesn't have any relation with the gender. So according to WHO, this iron deficiency, no anemia, iron deficiency, could be well advanced and cause clinical symptoms before hemoglobin reach those levels before 12 in women and 13 in males. So iron deficiency should be considered as a disease. And most of the guidelines just pointing towards if you have iron deficiency, without anemia, iron deficiency should be treated. Okay, that's it. That's the study was published in the Internal Medicine Journal in 2016. Good amount of patients, 8,000 people were enrolled in that. So now we are having kind of two concepts: iron deficiency anemia, which is the low level of ferritin with low hemoglobin, or only iron deficiency. So this topic just was visited by one of the speakers before. So iron sequestration anemia, that's the pathophysiology behind the anemia of chronic disease. What is happening here? So as you can see in this photo on the right, so the inflammation is going to trigger a lot of inflammation biomarkers. So you will have the interleukin-6. The interleukin-6 will stimulate the production of epsilon by the liver. What the epsilon does, the epsilon just blockade the gate from where the iron is just leaving the enterocytes, the macrophages, or in the bone, or in the storage recipients into the blood. So you will have a good amount of iron, iron in the storage, which is ferritin, a very low concentration of iron in blood. So for anemia, because the topic is for anemia in patients for a surgery. So I will try to divide the presentation for different scenarios: non-cardiac surgery, obstetric surgery, cardiac surgery, and emergency surgery. For elective non-cardiac surgeries, pre-op anemia affects 30 to 60% of the patients. So we are talking about a big amount of people. So, and it is, if you just go and dig deeper in this fact, it varies according to the surgery. You can see in the next paragraph, the gynecological surgery, 64% of the patients already have iron deficiency anemia. Colorectal cancer resection, 58%. It's understandable. Those patients have intestinal bleeding, losing iron, they have anemia, as a part of the pathophysiology of the disease. And on those groups, women are affected with a prevalence, more affected with a prevalence of 68.9%. So you already know a patient who is booked for a gynecological surgery or a colorectal cancer on female. So you just need to dig very deep in his chart and try to rule out the presence of iron deficiency or iron deficiency anemia. So the major cause of anemia in both groups is absolute iron deficiency. Absolute iron deficiency, you can see it here. It's just ferritin less than 30, saturation less than 20, and the hemoglobin into the normal range, okay? With a low epsilon. That is a very important topic, and I was just checking in the hospital in National Guard. So we are not doing epsilon. So epsilon will be something that we can use in order to rule out absolute iron deficiency versus iron deficiency anemia. So among the patient with anemia, 2/3 of them have absolute iron deficiency, and 10 to 50% have iron sequestration, meaning these patients have kind of this anemia secondary to inflammation. And 10%, you just very, very small amount compared with the rest are B12 or folate deficiency. So iron sequestration anemia, just remember inflammation, interleukin C, the liver start to produce epsilon. Epsilon just blocked the release of the iron into the bloodstream. You will not have enough iron to produce blood. Just trying to visit the pathophysiology. Anemia in elective non-cardiac surgery is associated with an increased risk of RBC transfusion, in hospital complication, delay hospital discharge, and very poor recovery. We are talking non-cardiac surgery. This kind of anemia, it is more evident in those patients who are booked for abdominal surgery, and is associated with a risk of disability very high after 90 days of surgery. So diagnosis of anemia and treat the anemia is a key point in order to try to have the better outcome possible for our patient going for abdominal surgery. So and also very important in terms of economic for the hospital, increase the unplanned ICU admission on these patients booked for abdominal surgery. So going to the other topic, cardiac surgery, anemia before cardiac surgery is affecting 40% of our patients. 40% of the patients booked for cardiac surgery. It doesn't matter what surgery is. So coronary artery bypass graft, valves, combined surgeries. 40% of our patients already are just booked for surgery with kind of iron deficiency or iron deficiency anemia. The perioperative anemia is an independent associated risk for increased number of RBCs, increased mortality, and longer hospital stays. So I think our goal in the settings of handling patient with perioperative anemia is just try to decrease the blood transfusion. All of us know that giving blood is not a benign process. Giving blood is associated with a lot of complications that we really want to try to avoid transfuse our patient as much as possible. So almost 50% of the patient with iron deficiency before surgery have kind of left ventricular systolic dysfunction. You already just visit the topic of heart failure and iron deficiency anemia and they treated. So at the treatment, so maybe treat this patient with IV iron just before taking as an elective surgery. It will be a good idea because you can improve a bit the systolic function of the left ventricle. So according to the WHO, to the WHO criteria, this value 12 or 13 women or male maybe is not ideal to assess the perioperative risk of blood transfusion during or after the surgery. So there is a very nice paper published in the Journal of Cardiothoracic and Vascular Anesthesia that they are trying to find what is the best marker in order to predict if the patient will receive or will not receive blood. Hemoglobin is not. They are mentioned that most likely is going to be the RBC mass. The RBC mass, it is a process just trying to take it because you need to mark the erythrocytes, and at the end you pass the patient for a radiograph machine, and you will calculate the RBC mass better than the hemoglobin. We are not doing that very often, but it's just most of the papers are pointing towards that we need to calculate the RBC mass in those patients booked for cardiac surgery in order to assess the risk of blood transfusion.
Andres, we lost the presentation again. If you don't mind, just like a few seconds ago, yeah.
It's back?
Push it, yeah, now it's back, yeah.
Okay. Is there?
Yeah, it's working.
Okay, so for our patient just booked for cardiac surgery, what are the treatment strategies? So just try to make it simple. If the patient hemoglobin level is more than 130 in men or 120 in female, for sure they have not anemia. If they have it. So and then we need to just book our patient or try to do all the iron study and then treat the patient before surgery. We will go through the treatment for No, move.
Yeah, it's back on now.
Okay.
And just a reminder, Andres, that we're almost, yani, time is cutting short, so
Yeah.
quick
So
reminder.
do you have the screen, the presentation
Yeah,
on
we
the
have.
screen? Okay. So let's just skip to the treatment. Is there?
Yeah, it's working.
Okay, so yeah, on this algorithm, so I just really want you to be focused on the left side, which is the most frequent we will have. So if you have if your patient is already labeled as an iron deficiency or iron deficiency anemia, so the first thing you need to do is, and it's very that practice is spread all over our hospital. So the patient has a dropping of the hemoglobin. We call the gastroenterologist in order to rule out a gastrointestinal bleeding. So I will say that maybe that's correct or maybe not. I prefer just to do occult blood and feces, be completely sure that there is blood in the gut, and then you maybe need to call the gastroenterologist. So when you talk to them and you have a occult blood and feces negative, it's very unlikely that the patient will have a bleeding in the gut. So why I'm telling you that? Because if you have a patient with a 30-25% ejection fraction, which is booked for surgery, you need to do an upper GI scope. You need to sedate the patient. So sedation in patient with a very reduced ejection fraction, it carry a very big risk in order to respiratory depression, hemodynamic decompensation, and maybe we should avoid to do that. Just be completely sure that the patient is not bleeding, and if the patient is fit based on the hemoglobin, we should start the patient on oral iron, dividing doses, or IV iron if the patient has intolerance to the oral iron. So it's what you already talk about these things. So enteral iron, the single dose of ferrous sulfate results in a rapid rise of the epsilon. We know what's the role of the epsilon. So that's why you shouldn't give the iron every single day. It's better to give the iron every other day. If you give the iron every other day, you will just jump this epsilon block, and the iron you are given is gonna do whatever you really want to do. Just produce more erythrocytes. So as a result of this pathophysiology trend, so you should give to the patient 40 to 60 milligrams of iron daily, or 80 to 100 milligrams alternate days. This is the current guidelines for iron given PO. So there are a new iron presentation. I will not dig very deep on this, but this iron is just covered by a special matrix that allow the iron to go through the stomach and the duodenum and the jejunum without any changes in the molecular structure, and it will cross very nice and easily into the circulation and will be used. The regular iron we are using, 60% of this iron is not able to cross to the bloodstream, and is the responsible with the side effects. So this presentation, they call this sucrosomial. It is very interesting to look after as a possibility for this patient with intolerance to the iron PO. IV iron, you already talked about the IV iron, the importance of the IV iron, and they bypass the epsilon block. So it is a good treatment for patients for elective surgery in which you want to increase the hemoglobin in the next 3 to 4 days. So increase with 50% the effect, and the effect is evident in 3 days. So you can give the dose, wait for 3 days, and maybe you can take the patient to the OR in 3 days. 75% at 2 weeks, and maximum response is happening after 4 weeks. So starting a patient on IV iron means that the patient will be ready for surgery in 3 to 4 weeks. So the current guidelines for the iron, it is the clinical trial improvement in hemoglobin with IV iron if you compare to oral iron or placebo. So the data also suggests that iron therapy treatment for the anemia should be only limited for patients with iron deficiency anemia. No for patients. We will just can discuss that in the question session. It cannot be given for patients with inflammatory anemia. So the contemporary presentation of IV iron are very safe in terms of side effects. So one of the effects, which is the hypophosphatemia. So it's very infrequent, but it can happen. So those patients with a chronic iron, IV iron treatment can have osteomyelitis or fractures. So it can just be a good idea to just check the phosphatate levels of our patients who are in IV, on chronic IV. There is conflicted data about risk of infection and the extravasation of this. This is a very typical. You see a patient with this color, is a patient getting IV iron. So what the literature suggests about the treatment. So you can see on this table very nice 5 studies of iron given IV. So it is discouraging if you just think about the iron. A lot of conflicted data. So there is no different. At the end of the day, what we want to give the iron, improve our RBCs, and do not transfuse the patient. There is no big changes given IV iron on the rate of transfusion. So at the end of the day, should we just keep giving iron to our patients or not? Let's carry on with the presentation. So when you give iron with something else, which is you give iron with the tranexamic acid on this patient going for cardiac surgery or surgery with higher risk of bleeding, you are able to decrease 50% the amount of RBC given to the patient. So is the iron or is the tranexamic acid or is the combination? So this is something we need to dig a little bit deeper in further studies. So when you just check the literature, IV iron alone really do not decrease the RBC transfusion in our patients. The clinical use of the ASA, so it can be given. So only on those patients who you are completely sure that the patient has a sequestration of iron. Your ASA is erythropoietin stimulating agents. So all of this is just published in this a very nice article from NICE. Just escaping, just having the treatment with erythropoietin stimulating agents is very controversial, and you check all the literature, and you don't have any very objective idea if it can be given or not. So in this slides, I will just point to the same thing. Erythropoietin stimulating agents plus tranexamic acid maybe is the solution, but given alone for surgeries that are going to be booked for 3 or 4 weeks is not the option. So iron combined with erythropoietin stimulating agents, that can be, and according to the guidelines, is the best way to be given. So when you give it with the iron, you can see on the right lower proportion of transfused patients and less RBC requirements on the first study to 74 patients, 494 patients in 2019, less RBC transfused on an intervention group. And in this study in 2022, they enrolled 158 patients, and also fewer RBC transfusion in the intervention group. Blood transfusion is a big deal. A lot of complications can happen with the blood transfusion, immunologic, non-immunologic. A lot of syndromes described with transfusion of blood, TRALI or TACO. We really want to get off this complication in our patients who are going to receive blood. So patients with a cardiovascular disease, the evidence suggests a higher rate of myocardial infarction and trend toward higher mortality in those patients who were just fitted on these restricted transfusion strategies. I'm just skipping this, try to go to the
We'll have one more minute, Dr.
Okay,
Fernand.
that's good. Regarding the blood transfusion, so potential benefits of the blood transfusion must be considered in all our patients because it increase the risk. Those risks mainly are TRALI and TACO. TRALI is transfusion-related acute lung injury, and TACO is transfusion-associated cardiovascular overload, can produce non-hemolytic or hemolytic reaction. RBC transfusion for the treatment of anemia adds a lot of risk for our patient. So RBC transfusion contribute with very, very bad outcomes. So transfusion anemia represent very safety concerns in terms of just giving the blood to the patient. An RBC transfuse only can be considered for symptomatic patient in which you cannot, you need to replenish the intravascular space of this patient, and you cannot do it in 4 weeks because the patient needs to be taken to the OR in an urgent fashion. So message to take home regarding the surgeries in patients with cardiovascular disease, iron deficiency, anemia, and all the treatment strategies. So it is maybe 6 or 7 conclusions I can take it. So correcting anemia remains a very difficult and very often unsuccessful combined with administration IV iron or ESA. This combination seems to be the most prominent target for treatment. So even with intensified therapies, meaning IV iron plus oral iron, or IV iron plus ESA, sometimes you are not able to reach the target of the hemoglobin you want to put the patient on before going for surgery. So very important thing before surgery, all of our patients needs to be screened for anemia, because if you just diagnose the anemia on time, you can act accordingly and try to improve the physical condition of your patient before the surgery. So the patient with iron deficiency anemia, IV iron is general or mainly preferable to be given before oral iron. The available suggestion for the elective surgery for the erythropoietin stimulating agents are not the best for patients with IDA, are good for the patient with inflammation. The only issue with the ESA is the treatment duration, even the dose. It is not very well established. On one of the studies I just showed you on the table before, it is good if you add a tranexamic acid for this patient in a pre-op period in order to reduce the blood transfusion. So when the patient is on ESAs, it's important to put the patient on prophylactic anticoagulation. They have a high risk of developing DVT. So it's good to have your patient in the DVT prophylaxis. So RB transfusion may be considered for severe symptomatic operative anemia, and the clinical need cannot meet when you cannot optimize the hemoglobin in a fast way. Sorry for the issues with the screen.
It's okay. Thank you, Dr. Fernandez, for this talk. And I think at this stage now, we discussed thoroughly a couple of subjects that's very important, and we have some question in the chat that we're going to go through them. We have around 8 to 10 minutes for discussion, so hopefully we can cover all the questions. So anybody still have a question in mind, please do type it in the chat or the question and answer. So I will start with the first one, probably directed to Dr. Ismail Ruslan. They're asking about the SGLT2 inhibitor use. That's probably, there is some data, it's improving hematocrit value. So does that will decrease the requirement of IV iron given? And there is some data right now suggesting that both together are not are replenishing the benefit of IV iron. So Dr. Ismail, any thoughts about that?
Thanks, Ibrahim. There was actually a really good paper about this that was published in JACC, I think about 6 months ago, that tackled this question. I find it to be really interesting because there are 2 main mechanisms that they mentioned. The SGLT2 inhibitors seems to actually promote erythrocytosis. And another mechanistic matter that was discussed was that it works on something that calls the cardiac myocyte adenosine triphosphate production. So ultimately, you might get a diminished effect of anemia on the long term in these patients. But at the end of the day, what I think my strategy is, if your patient is truly iron deplete, at that point, I would not mitigate about anything. So if I have a patient where I'm capturing right now and my investigations declare that he's truly iron deplete, I'm not going to wait for an SGLT2 inhibitor to basically mitigate against that. I would treat him given the fact that the symptoms get better, they feel better, etc. But definitely, we don't have a clear mechanism to how this works, but it's very exciting to see where it's heading.
Excellent. Second question, I'm not sure if I can get the question very well, but they're asking about CHF is associated with iron deficiency, as we mentioned. What drugs do you recommend, angiotensin blocker, and how to manage the association of the CKD? So I think probably part of it is out of our scope, is in terms of which medication we use for HFrEF or HFpEF patients. Angiotensin receptor blocker is a class 1A for people with HFrEF. Regardless of the iron deficiency anemia. So we just discussed people who have iron deficiency anemia, we give them IV iron, as mentioned in the previous protocol, regardless of the treatment for heart failure with the medical therapy. So that's two different or separate issues. And I don't think there is an issue with the CKD in terms of the IV iron supplementation. I don't think there's any data about the safety of that I know of. Do you know anything, Dr. Ismail, or?
I agree with you. I think maybe one of the questions that the person who asked is going for is there has been some mechanistic studies looking into increased risk of anemia for patients that are being treated with ACE inhibitors, for example. So if you look at the trial that looked into Entresto or sacubitril valsartan versus enalapril, there seems to be a higher risk of anemia in these patients. But whether this is causality or association just because of your patient being sick, I think that is the point of reference here. It doesn't seem to be seen with ARB, though.
Okay. The next question, can someone shed a light on the newly approved ferric carboxymaltose injective? So I think they mean ferric inject for iron replacement. So basically, it's not newly approved. I think it's there. It's one of the major ones that we use. There's a ferric carboxymaltose, as Dr. Ismail lay out in his summary of the trials. Most of the trials that show, I think, significant benefit was with the ferric carboxymaltose. That's why is specifically mentioned in the guideline. I think the European added another medication that's skipping my head, and the Saudi guideline specifically mentioned ferric carboxymaltose as a tool of replacement. So do you want to say anything more, Dr. Ismail, about that, or?
Yeah, I think when we're looking to iron replacement IV, we have about 4 different types of formulation. You need to know where the trials are done, and really the biggest recent randomized trial are on 2 agents. So the first one we talked about was the ferric carboxymaltose, and the second one was the ferric deoxymaltose, which is a different type of formulation.
Okay, excellent. The next question, hemoglobin target in heart failure and increasing hematocrit can increase thrombotic event. Maybe I don't believe we have a specific target for hemoglobin. It's different, I think, than coronary artery disease or a CKD patient. We need, as Dr. Ismail mentioned in his lecture, to screen at the beginning of the diagnosis and then frequently pre-discharge when they come with heart failure, or if they are stable in the clinic, to screen for anemia and for iron deficiency and treat if appropriate. I don't think we're gonna we know that the evidence with the hematocrit or the hemoglobin above 15 is questionable. So at that time, I don't think there is an increased risk of giving IV iron if the hemoglobin is below 15 to increase the thrombotic event. I don't think that's the case. The next question is hemoglobin target, it's the same question only, or we should monitor also hematocrit and maybe affect diuretics. And so I think there is a slide that you mentioned, Dr. Ismail. Maybe you can mention it about the follow-ups. So maybe you can just reiterate in this about the target. It seems there's a question about, do we have targets, or it just give the replacement and then follow up?
We definitely have targets. As we mentioned, the most important thing is it's not a one-time thing. So you give it, you calculate how much is deficient, but then in intervals, you have to keep coming back and checking and follow the same guidelines that tells you if your patient is basically deficient or not. So if your patient is still deficient on the 12-week follow-up, the 24-week follow-up, it tells you need to keep on catching up with your IV iron.
But I think we don't have a specific number of hemoglobin that we need to reach above to stop replacing. It's basically about checking the iron stores. So the definition, as we mentioned, checking the ferritin, the oxygen saturation, and if your hemoglobin is still below 15, you still have evidence to give more replacement, as we mentioned.
100%. So what you're looking for in follow-up is not a number of hemoglobin, because we mentioned before that patient can be iron deficient with or without anemia. But I can tell you, whenever you start repleting and you're filling the bone marrow with the materials that it needs, your hemoglobin eventually tends to trend upwards.
Okay, so mashallah, more questions are coming, so I'm going to try to go through because of the time. So any adverse reaction from IV iron therapy? Anything that you should just highlight, Dr. Ismail?
I think there are a few important things. It really depends on the formulation that you're using. Some of these actually come in from anaphylactic type reactions, but this is really with one of the previous type of formulations that we don't use right now. So essentially that was the iron dextran. You actually need to give them a little bit of iron just to make sure that they can tolerate it, and then you give them the full dose. But when we're looking at the newer formulations, even when we're looking at one of the newer trials, the event rate is actually very, very low. So we're talking about less than 1 in 1,000 in these patients. But primarily, you tell them about hypersensitivity, you tell them about rashes, etc. One of the important things that tend to show up with the carboxymaltose formulation is hypophosphatemia. But it's never to the point where it's problematic. It's usually in the mild to the moderate range as well.
Excellent. Next question, any data on heart failure outcome of treating with IV iron alone versus IV iron plus RBC in heart failure? I think from just listening to Dr. Ismail today, I don't think we have a trial, or we don't usually routinely give RBCs unless patient different, like in different scenario, actively bleeding, hemoglobin less than 7. I think it's a, I don't believe we do it as a routine with the replacement, right?
Agree, because in the end of the day, it's a completely different beast. Because at the time being, when you have that patient in that situation, you have a depleted iron store that you want to tackle. So the problem is not the oxygen carrying capacity, it's just that I don't have the building blocks to allow you to generate the necessary RBCs. So personally, especially when you're talking about advanced heart failure, I really want to shy away from giving you red blood cells because, you know, it's immunogenic as well. It decreases your likelihood of getting a transplant in the future, etc. But there's no evidence, up to my knowledge right now, that iron deficient patients are given RBCs. We tackle replacement.
Next question, any data in deficiency and other trace element in heart failure that you know of?
Definitely as well. So selenium, for example, can be seen in patients. You're looking at vitamin C, vitamin D as well. Some data, a little poor, but for vitamin A, for example, as well. And of course, iodine and thyroid dysfunction.
Okay, but I don't think none of them still like reach the guideline with a very strong recommendation so far. Okay, what about the next question? What about roxadustat efficient? I'm not sure if you can help me, Ismail. Does that make any sense to you, or I should just skip to the next question? Roxadustat efficiency. I think I'll just go to the next one.
If my memory serves me correctly, this was a type of medication that increases the production of erythropoietin and stimulates the production of red blood cells. But I'm not aware of any current randomized clinical trials that tackles it.
Is that something that, Dr. Fernandez prior to cardiac surgery, do you have any evidence about using erythropoietin stimulating agents, or? Okay, Dr. Fernandez, are you with us? Okay, I'm not sure. Maybe he's muted. Okay, so I'll ask the next question and see if he hears us after. This study can I use in pediatric or only study only in adults? I'm a pediatric cardiology fellow. We give iron, but now only we have evidence. Thanks. So correct me, Ismail. Most of the studies I think that we discussed today was in adults. Do you have, like, I know it's a difficult question, but do you have anything in pediatric in mind, or we should just defer this question to our colleague in pediatric cardiology?
Most of what I've seen were more than 18 years of age to be included.
Okay, okay. So what is the efficacy of roxadustat in ischemic heart disease and CKD with poor tolerance to erythropoietin? So I think that's the same substance that you mentioned about the erythropoietin stimulating agent. As far as I know, I don't know about evidence in coronary artery disease in such agent. Maybe CKD is different. That's out of the scope of our specialty. But do you have anything to add, Ismail, in this regard, or no?
Not really. My understanding is it's for CKD. I haven't came across it in heart failure or coronary artery disease.
Okay, okay. Next one, I think they just mentioning because it was skipping my head. The second name medication is ferric dorsey maltose. So that's the one that's mentioned in the European guideline, I think, with the ferric carboxymaltose in improving quality of life for patient with iron deficiency anemia. Side effect. Fishban effect, hypophosphatemia only in patient with frequent IV iron use and can be easily corrected with supplement. Yeah, so I think Dr. Hisham Hussein, I'm not sure if it's said the name correctly, but I think they're reiterating what Dr. Ismail said, that the hypophosphatemia are not that significant and can be corrected easily with supplement and will not shy us from getting the benefit of IV iron that we just discussed. There is a short-term trial for combined ESA plus IV iron pre-CABG showed promising results. So yeah, I think that's why I was asking Dr. Fernandez if he.
I'm here. No.
Yeah. So they're asking about the medication, the roxadustat, I think the erythropoietin stimulating agent, and if we have evidence for that. So I was mentioning that probably the evidence is prior to the cardiac session, as you mentioned.
Yeah.
Can you
So
iterate more?
there are a couple of papers just mentioning the use of the ESA previous cardiac surgery. So on the three papers I reviewed, so the increase in the RBC is kind of okay if you start the treatment maybe 3 to 4 weeks before the surgery in an elective fashion. But at the end of the day, what are you looking just on those patients? Try to reduce the RBC transfusions. And the only paper able to prove the decrease in an RBC transfusion was a paper which they enrolled 450 patients, but plus the erythropoietin, they add tranexamic acid. At the end, they were not completely sure what happened. Was the tranexamic acid with decreased RBC transfusion rate, or was the erythropoietin given to the patient? But on my conclusion, I put that if we are going to use the ESA in patient previous cardiac surgery, it can be CABG or it can be valvular surgery. So we usually in our practice, we always give a tranexamic acid, 2 grams before the pump and 2 grams after the pump. So if you are going to use this kind of a regime, I will use adding tranexamic acid.
Okay. Excellent. So I think those are the questions that we have, and I think we reached the conclusion of our session today. So if I can just emphasize, like in 30 seconds, just to recap the whole thing, heart failure and cardiovascular disease, high burden, need to do more to your patient. We need to check IV iron at the beginning of the diagnosis and continually to screen patient for iron deficiency and not just only anemia. So iron deficiency also by itself. And we need to replace that with IV iron, as Dr. Ismail mentioned, with the protocol that he lay out with continuous follow-up. So not just replace and forget the patient. You have to replace and keep following. And we have to screen patient prior to OR, as Dr. Fernandez mentioned, because anemia is shared with worse outcome and transfusion, and doing a good job by replacing with IV iron. And some of the evidence with the other medication can help improve the outcome of your patient. So again, thanks everyone today for coming. Thanks for Dr. Ismail Raslan, Dr. Andres Fernandez for their valuable time. Thanks for the National Heart Center, with special thanks to Dr. Adil Tash and Dr. Wael Qashqari for giving us the support. And inshallah, this will not be the last lecture. It will be one of many in heart failure, bismillah. And hopefully we can see you all in the next series.
If you don't mind, Dr. Ibrahim, just one last comment. I would like really to thank Rakan Filimban and the CSL V4 for the support. Without them, we will not be able to do this national webinar. And as you said, Dr. Ibrahim, that inshallah this will be the first in a series. It will be very well organized, and it will every single attendee will receive the lectures by email, and with time, hopefully we can even send the entire recorded video to their emails. I would like to thank you personally, Dr. Ibrahim, for sharing and putting this amazing program, and Dr. Ismail Raslan and my close friend, Dr. Fernandez. I'm very happy to see you, and thank you for the attendee. And the last, I would like to thank Ala and Fadl from Red Sands for doing this huge effort. Thank you very much all, and God bless you, and have a good night.
Thank you very much, everyone. Enjoy the rest of your weekend.